Welcome to the latest installment of the AST Journal Club series. Today's Journal Club features the Hepatology Communications article, Parental Leave, Childcare Policies, and Workplace Bias for Hepatology Professionals, a National Survey. This session is sponsored by the AST Health Community of Practice. In a moment, I will turn the session over to our moderators, Dr. Rotonya Carr from the University of Washington in Seattle, Washington, and Dr. Nicole Alvey from Rush University Medical Center in Chicago, Illinois. Before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. If you have a question for our panelists during the Journal Club, we encourage you to participate by using the Q&A button in your Zoom webinar panel. Questions submitted via the chat window may be missed during the presentation. This Journal Club is being recorded, and the archive will be available on the MyAST website in 2 to 3 business days. Finally, when you log off at the conclusion of today's Journal Club, you will see a link to a short evaluation survey to complete. Please fill out this survey to help us keep our content current and engaging. And now, I'll turn the session over to our moderator, Dr. Carr, to begin our presentation.
Welcome, everyone. We are so excited to hold this Journal Club today, and it is my very special privilege to be joined here with my co-moderator, Dr. Nicole Alvey from Rush University Medical Center. I get the honor of introducing our speaker for today, Dr. Lauren Feld, who is a transplant hepatologist and an assistant professor of medicine at the University of Massachusetts Chan School of Medicine. Her clinical practice focuses on women's health in liver disease. She also is the Diversity, Equity, Inclusion, and Belonging Executive for the Department of Medicine, the first of its kind. Dr. Feld completed her clinical fellowship with us at the University of Washington in GI and also her transplant hepatology fellowship there. She also holds a master's degree in clinical medical ethics at the McLean Center for Medical, from the McLean Center for Medical Ethics at the University of Chicago. Her leadership position at the University of Massachusetts has focused on improving workforce gender equity, and her lab also focuses on these issues. She considers her research to be at the intersection of gender equity and medical ethics. It is my honor to welcome Dr. Feld as our discussant for today.
Thank you so much for the kind introduction, and I'm thrilled to have the Journal Club focused on this article that is both near and dear to my heart, and I think also critical for some of the issues that medicine is facing these days. And so without further ado, we will dive in. I have no conflicts of interest. I did want to mention that when the study was performed, I was working with the AASLD Women's Committee, and so I listed the members of the Women's Committee who were instrumental in working on the survey, and particularly wanted to shout out Doctors Monica Sarkar and Erica Villa and Lauren Nephew and Vinny Aurora, who were particularly instrumental to the survey. And these are the conflicts of interest for the moderators. So the background for this is that we know that parental leave is important. There is an extensive base of literature supporting the importance for infants and for parents. There are short-term impacts on both child well-being and also parental well-being for all genders of parents. We also know that there are long-term studies that show roles related to caregiving, closeness, and parent-child relationship many years out from leave. They've studied things like high school performance and associations with parental leave. So we know that there's a very large literature base supporting the importance of parental leave. And understandably, many medical societies have endorsed parental leave, including the American Academy of Pediatrics, which recommends 12 weeks of paid parental leave for all parents. It is notable that many physicians are unable to take what is endorsed by medical societies. And we know that parental leave may contribute to issues of workforce gender equity. So specifically, a study of internal medicine residents that was done recently in 2022 saw that the number one reason that internal medicine residents reported that they were not going to choose a fellowship in GI and hepatology was concerns about perceived incompatibility with pregnancy and with child rearing. So this impacts our pipeline. There are nationwide issues with retention and concerns about turnover of women in the healthcare workforce. And multiple studies have identified that difficulties balancing caregiving responsibilities, particularly for children, is a major driver of needing to reduce clinical time in the workforce for women and considering leaving the workforce for another position. There are also studies of gender bias and discrimination that have related from caregiving responsibilities and parental leave. And no prior study had evaluated this in hepatology. So the ASLD Women's Committee submitted a survey. It was distributed through the listserv in 2021. The listserv went out to the 5,400 contacts. These are physicians and also included a broad number of other professionals. We specifically recruited physicians in the United States. So we excluded other respondents from the survey. The 33-item survey included demographics. We asked about childbirth. So how old were you when you had your children? We asked about each specific childbirth. What was your career stage? How many weeks of parental leave did you have? Were those weeks paid, unpaid? Did you take them from other protected times, such as vacation? We asked about health and pregnancy complications. We asked about impact on training, career. We asked questions about bias. We asked about impacts on family planning and childcare, and asked about work environments and work accommodation. So it was an extensive survey that we ended up having 133 women and 69 men who responded to the survey. There is a skew, so 65% of our respondents were women. When you send out an email that's from the ASLD Women's Committee, understandably, I think it directs to a slight skew in respondents. We had a nice range of ages, so we have hepatologists from across the spectrum and training. You can see our race and ethnicity data here. And practice settings. The majority of our respondents were academic and primarily clinical. I think that's probably reflective of the ASLD listserv. And then about 5% in private practice, and a few others who reported they were in industry or other employment settings. We first want to talk about workplace discrimination. I will mention, so this was an extensive survey, and I really want to leave time for the discussion portion of this journal club. I think that will be really important and high yield. So we'll cover a few important areas and then move on to the discussion. For workplace discrimination, excuse me, 3/4 of women reported workplace discrimination. So 75% of women said that they had experienced discrimination compared to 37% of men. And Black and Hispanic women more frequently reported types of workplace discrimination. So overall, 83% of Black women and 62% of Hispanic women reported discrimination. If you can see this graph, notably areas like pay or benefits not being equivalent to peers, not being fairly considered for promotion or management, being held to a higher standard of performance than peers. And so many potential areas where people reported discrimination. When we ask specifically about parental leave, this is for their first child. Most of the children reported had similar duration of paid parental leave. Women on average took 7.5 weeks of paid leave and 3.7 weeks of unpaid leave. 4 weeks were taken from other protected time. Excuse me, things like vacation and research. Men took a much shorter leave duration, 1.7 weeks of paid leave for men, less than 1 week of unpaid leave was taken, and 1 week from other protected time, such as vacation. The majority of women, the highest percentage of women who reported their first childbirth had that in fellowship. So it highlights fellowship as a pretty critical time for when 43% of women hepatologists had their first child. An additional 30% had their first child as an attending, and 24% had their first child during residency. Importantly, 90% of our respondents had fewer than 12 weeks of dedicated paid parental leave. So 90% had less than what the American Academy of Pediatrics and multiple other medical societies recommend as the appropriate duration of paid leave. And I'll mention that there's an increasing number of states that are mandating 12 weeks of paid leave. And so what we're finding is that a lot of the hepatologists sort of were taking less than is recommended and less than is increasingly required by many states in the US. There was an impact on, you'll have to forgive me. I'm blessed with one of the many toddler viruses that come home from preschool, so my apologies. When we asked about impact on training and career, we found that more women altered their career plans because of child rearing, pregnancy, or adoption. So noting that this is sort of disproportionately impacting women, and we want to think, when we're thinking from a gender equity perspective, lack of adequate parental leave does impact women. When we asked about what sort of career impacts there were, altered career plans, extended training, reduced research time, and many reported bias about about their own parental leave and child rearing, or about the parental leave and child rearing of others. So 46% of all respondents had perceived bias about either their own parental leave or that of others. When we narrowed the respondents down to people without children, so the people who responded to the survey but did not yet have their own children, 0 men reported that they had noticed bias about parental leave of others, and 46% of women without children noticed bias about parental leave of others. So clearly there are messages, whether explicit or implicit, that are given to women hepatologists about child rearing and taking parental leave. An important time for everyone's career development are interviews, excuse me. So we asked about pregnancy. So we asked about if you were asked about pregnancy during fellowship interviews. And speaking of the career impact of having children, my 2-year-old is really doing me in for this, so my apologies. So 20% of women were asked during a fellowship interview about their intentions for pregnancy or having children. So this is certainly something to consider if you think about your own institution and the training that people get before they're interviewing people for fellowship or attending positions. You may want to make sure that everyone is being consistent about the questions that they're being asked. When I interviewed for fellowship, this is a picture of me right before my last fellowship interview. No one needed to ask. It was pretty obvious when I walked in the door. But I did write an article about that experience interviewing for fellowship, and I'm thrilled to have had the chance to experience fellowship at the University of Washington. Not every place was as accepting, and so I did write an article about that if you're interested. When we asked about family planning and fertility, 69% of women reported that they delayed having children. And so I do want to note that I mentioned at the beginning that some of the internal medicine residents expressed a concern about pregnancy, about incompatibility of doing GI as a career and hepatology as a career because of concerns around pregnancy and childbearing. And this is to say that wasn't necessarily an incorrect perception. 69% of women hepatologists reported that they had to delay having children, and 35% reported job-related stressors contributed to an adverse outcome of pregnancy. So this is clearly something that medicine residents are picking up on before choosing our field, and something that they're not wrong about. So it's an important thing to address when we consider our pipeline. When we asked more granular details about the impact on family planning, we found that women reported they delayed pregnancy because of a concern about lack of parental leave, excuse me, or sufficient parental leave, concern about the impacts on their colleagues and career concerns. Men were significantly more likely to have children and had a higher number of children. So men hepatologists were, because of the typical differences in the physical stress of childbearing, were able to have more children. 80% of women reported overnight calls in their third trimester of pregnancy. And a study in surgeons had found that 6 or more overnight calls per month were associated with health issues during pregnancy. So we also looked for that in our findings and found that those hepatologists who reported 6 or more overnight calls per month also reported higher numbers of complications during pregnancy and delivery. 57% of the hepatologists reported at least weekly overnight calls in their third trimester. Many women changed their schedule during pregnancy, but interestingly, over half of those changes were actually front-loading, increasing the difficulty of their schedule, so taking up more calls during pregnancy in order to try to sort of pay forward for their parental leave or the time that they were going to take off. 69% of women didn't change their procedural volume during pregnancy. So anyone who has tried to do endoscopy while pregnant knows some of the challenges associated with this. And the vast majority of women carried out sort of their full procedural load during pregnancy. We also asked about work environments. So we asked about breastfeeding and protected time for lactation. 50% of women reported, only 50% reported adequate space for pumping breast milk, and 17% reported adequate time allotted for pumping. So I will note that this is actually one of the few areas that the US is an outlier for many countries in that it doesn't mandate paid parental leave, but it does mandate paid protected time for pumping and breast milk. And so only 17% of women reporting adequate time. This is actually illegal. That everyone should be able to have time for pumping and for, and so the fact that the vast majority of hepatologists reported that this wasn't available to them really identifies some systems issues that are incompatible with where work environments are supposed to be. And then we also asked about childcare, because balancing childcare, it can be very challenging. And so 23% of women reported a hospital-affiliated childcare, and 17% reported childcare on the premises, which is certainly one of those structural interventions that can increase people's ability to balance their work responsibilities. These are some of the references that I mentioned. And then we can move to the questions and discussions. And I apologize again for my my coughing during the presentation.
Thank you so much, Dr. Feld, for going through this. And I promise we didn't pay your 2-year-old to get you sick prior to the presentation to drive home the point of what moms can face in their careers, both before and after having children. So we appreciate you powering through the toddler virus. So I encourage any audience members to put any questions in the question and answer section of the Zoom call. But I will go ahead and get us started with the question that you said you get often, and probably is the question on everyone's mind. So I will go ahead and ask that. So given kind of this systemic bias that's been built in over decades and decades in parental leave and childbearing practices for women, what are some of the things that we can start to do now to start to fix some of these systems issues related to this?
It's a great question. You're right. It is one that I get often. So I included a slide on this. This is an article that I wrote to address this. Let me swap this so you have it in the full. It came out recently in the last year. It's focused on gastroenterology and hepatology in general, so it's not transplant specific. But if we do not plan ahead for leave, one of the major pushbacks when we talk about parental leave is that it is true that if you, everyone who works in a transplant space, anyone really in a healthcare space, is often incredibly busy, devoting a lot of their life to providing high quality care for patients. And when we talk about 12 weeks of leave, people who can believe in the benefits of parental leave, believe in that that's important, can also say in the back of their head, I'm already incredibly busy. And if I have to cover my colleagues' clinical load on top of my own clinical load for 12 weeks, that's a pretty significant impact. And so we want to think through what are ways that we can write into our structure that parental leave can happen without overburdening colleagues. And a lot of that requires planning ahead, not taking this as a surprise. Often when people are pregnant or are going to be on leave, you have advance notice. And so planning ahead and building structures in to support both the parent and their colleagues to make it, to have this protected time is important. So to address this common question, I wrote an article with wonderful colleagues on some of the ways that these can be addressed from a systems perspective. So for pregnancy accommodations, thinking through things like reducing overnight call burden. So that's something that in several studies have been, including the one we just discussed, has been found to have an association with pregnancy issues and issues with childbirth. And so protecting overnight call, making sure that there's anti-bias protection, thinking through ergonomic accommodations for pregnancy. There's also many women struggle with pregnancy loss, and it's often sort of felt that it is swept under the rug or needed to be behind the scenes. So thinking of things like bereavement protection and making sure that there's protected time for pregnancy and fertility appointments and tests. These are some of the things that when we build these into the systems, they actually help everyone, because everyone should be able to get to doctor's appointments. And so building in systems to make sure that workers can get to their doctor's appointments, it's not going to just benefit pregnancy. The parental leave policies should be transparent. They should be publicly available. So these are some of the things in my position at UMass that we're working with HR on. Anyone should be able to go to our website and understand what's available to them. You want to think through things like of making sure coverage solutions include team-based care models, potentially locums positions, so that you're not sort of overburdening colleagues. You want to be transparent about what compensation will look like. In different models, this might mean different things, but you just want to make sure that people are understanding. So if you're in a private practice model, you just need to know what that compensation will look like. And we mentioned also potentially additional compensation for colleagues who are covering additional responsibilities. And then once people have completed the pregnancy time period and they're now coming back into work with the responsibility of caregiving for children, thinking through things like modified overnight call when they're in that difficult transition period back, blocking out times for lactation so that more than 17% of women are saying that they had adequate lactation time, considering part-time and flexible work schedules upon return. If your structure can provide on-site childcare and coverage solutions for sick childcare. So something that I used last week, and it's available at many places. The UMass system has a backup childcare where you can request it online. They send someone to your house that's previously vetted. They pay for a portion of the cover of the care during the day. And so there are certain, and it's a nationwide service that's offered that helps the employees still be able to come to work even if they have a sick kid. And then thinking through equitable promotion policies so that you're not penalizing people for parental leave or people who do choose to reduce their work hours. So curious for your thoughts on that, Dr. Alvey, and particularly for your thoughts, Dr. Carr, as a division leader.
Thank you, Lauren. Yes, as a division head, I think about this question always. We have many trainees who are starting families, many faculty members who are starting or are growing their families, and really working to try to put in place structures to accommodate as best as possible. I have to say that on an institutional basis, it is quite variable. And I think I'm in the state of Washington, where the policies have been the most wonderful that I've experienced. We have now a paid leave policy that's 12 weeks in the state of Washington, and up to, I believe, actually at the maximum 18 weeks if someone has a C-section for a delivery. And this policy is not only for pregnancy, it's for parents, it's for also family leave. So it's a pretty broad policy that employees get access to. I don't know how many other states have this kind of a policy, but I think when you have protections, legal protections, state-based or federal, I think that really helps institutions. It gets them to do the right thing faster. There is a lot of cost to these accommodations. And so one thing that I've personally been struggling with as a division head is how do we strike the balance for trainees as well as for faculty. On the trainee side, there's a balance. There's I guess a financial consideration, but there's also a competency consideration when I think about costs. And you covered a little bit of that in your article. I'd love to hear more about that if we get a moment. And then on the faculty side, largely it's not only the financial cost, but also the cost to the team. And you mentioned morale, and everybody's burnt out. And so how do you strike that balance? I don't have any great answers, but it is something that I think as a division, we just accept that we're going to cover. We don't ask questions, we don't make people find their own coverage, etc. But it is, a short strain to the system. We don't have other levers to pull. I don't think that fully answers your question, but I think your list does really cover, a great array of opportunities, even things that we can do now that are small and maybe not so costly, and other things we can certainly work toward.
Excellent, thank you. One question that came up in the chat is, the question is, I realize these data were not part of your survey, but do you in general believe these problems are as significant in other related professions, such as PAs and nurses? As a non-physician, as a pharmacist, I can say it's certainly relatable to my profession as well. I remember with my first child, I kept going down to my boss's office every 2 weeks to keep showing him my growing stomach and saying, this is happening. So what's the plan? And it was 2 weeks before my due date that we finally had a plan in place. And then I went 5 days early. So, to your point about small things that we can do planning ahead, this isn't something that you drop on somebody the day before their due date. And I think it's extremely helpful to plan ahead for every person involved, so person going on leave as well as the others that are left to cover, so to speak, because I think that not only goes a long way in just the logistics of the coverage, but in terms of the attitudes, as you discussed, the biases of, when someone else sees a situation like that happening, they might not be as inclined to, want to move forward with their family planning. So I definitely think that these related professions have the same issue. And I guess I'll take that opportunity to also say that from the transplant organization standpoint, WHCOP is working to do a similar study as Dr. Feld and her colleagues did with AASLD on transplant professionals. So we are hoping to move forward with a similar survey and get better data about how this is impacting not only physicians, but all staff involved in the care of our transplant population.
Yeah, I'm very excited for this, and kudos to Nicole for leading these efforts, because that was a main limitation of this survey. I think it is because there are such differences in training, like what is a fellowship, what are the postgraduate trainings, et cetera. It was an understandable first step to limit this to only focusing on hepatologists. But I think that it definitely applies more broadly. And so it's going to be a real growth in our understanding to expand this survey to everyone in the transplant community.
There's another question in the chat. Dr. Monica Sarkar asked about adding formal curriculum at the level of residency. She notes that even things like financial management are not covered while we are, residents in training. And should we think about dedicating some sessions during this training period to talk to trainees about data such as what you presented, Lauren, so that they are prepared when they go on the interview trail and know what questions to ask?
Yes. I agree with that in the most part. So I think that every residency should have a lecture where they talk about parental leave and what is available at their institution, what the pathway will look like, and to talk through some of these issues around taking parental leave. I know I have, because of my work in this area, I have many trainees who approach me from a variety of institutions with questions like, when can I have kids? What are some of the implications I should think through? What are the career implications, et cetera? And so there is certainly a broad desire in trainees. I also think that the impetus, and one of the wonderful things about Dr. Sarkar's question is it's taking the impetus away from the trainees to ask. I think every fellowship program should be providing people with an upfront during their interview day. This is our parental leave policy. Because it puts trainees in an uncomfortable position to have to say, I'm considering growing my family. Can you tell me about the parental leave? Because there is a lot of bias. And I don't know that I would actually encourage trainees to ask about it during interviews, during their formal interview session. I think asking whether you're interviewing for residency or fellowship, asking the residents and fellows is probably a good thing. But if you're sitting down with the program director, I don't know that it's the best time of your 30-minute interview to ask about the parental leave policy. And I would hope instead that it gets handed to all trainees. And I know the programs that do that, the trainees register it as this is a program that is thinking about these things and friendly towards these things. And so it can have a real positive impact, especially if you're thinking of sort of recruiting a diverse group. And thinking through things like what are the childcare options and the different hours, because particularly trainees who work long hours, you want to be thoughtful that not all childcare solutions will work for you. And so actually having some of those conversations up front can help reduce some of that workload that could potentially, burden colleagues later.
Lauren, I have a question. You didn't really cover this in your talk because you just couldn't. There's so much. I hope everybody reads the paper. There's just
so much.
There's so much. I read it a couple times, and each time it's like I'm learning something new. But I wanted to talk about, not that you represent the APA, but there are different policies. The APA has different policies for faculty versus trainees in terms of paid time off. Can you talk to us about why you think that is, and are you proposing that it should be 12 weeks across the board, regardless of where someone is in their career, or do you think there is something different about the trainee period that we should be thinking about?
Yeah, and I love that you mentioned competency, because that's such an important question when, every faculty member who works in training, you want to make sure that you're graduating people who you would feel comfortable as if they are going to be caring for a member of your family. That's the crucial responsibility for everyone who's in a training position. And so you need to make sure that that you're proud of your graduates and that everyone has the time needed for competency. There is a movement in graduate medical education that is focusing more on what they call competency-based education as opposed to time-based training. And this has nice effects for people who are interested in taking parental leave, because it is certainly possible that someone can graduate a training program having taken 12 weeks of paid leave and be competent and able to practice independently at a high quality. And it's also possible that another trainee might not be able to. And so what competency-based education does is it's sort of evaluating that trainee specifically and saying, okay, even though you did this program in 2 years and 9 months as opposed to 3 years, we have clearly assessed you as competent, and so you're ready to graduate on time. And to the other trainees, say, you might need a little bit more time, and so we're going to extend your training by a certain amount. And so it's focused on the individual trainee. For training in particular, there's a few different bodies that govern when people can graduate. So one of them is the board eligibility. And so the ABMS, American Board of Medical Specialties, and sorry, this is physician focused, so it might not apply to the other healthcare professionals, but the ABMS had initially had a policy that said that if you took more than 4 to 5 weeks away from training in the year before your boards, you were not board eligible. And that went away in 2021. So now you still can sit for boards, even if you have taken leave. The other two policies the other two governing boards that influence this there's the ACGME, which has sort of their competency requirements, and ACGME recently updated their policies to recommend that each institution have a minimum of 6 weeks of paid leave that was offered. There are certain criteria that certain exceptions, so it's only required once during a training period. So if you have like the surgeons who are in training forever, the 7-year surgery residency, that they only have access to that parental leave once, but at least it's sort of saying that there's a minimum of 6 weeks. And then the last governing board is each institution's requirement. So each institution will have different requirements so you want to think about board eligibility, the institutional requirements, and then ACGME. Boards and ACGME have recently updated their policies to allow parental leave, so both within the last few years, which is a step forward. The ACGME policy of 6 weeks, and to your question of do I think everyone should have 12 weeks, the data that look at the benefits of parental leave support 12 weeks. And so that, as someone who believes in following the evidence, that's what I would recommend that every trainee have access to. I think that they should have conversations about what that means for their, some trainees might have to delay their graduation if they are not competent yet, and that there might be sort of other implications associated with that. But if I could with the snap of my fingers recommend something, then I would recommend that everyone at least have access to 12 weeks of paid leave.
Thank you. We had another question in the chat. To Rotonya on so about going back to trainees and being tough on the trainees who don't have kids or don't want kids right now, but have to provide that extra coverage. And so any thoughts on ways to compensate or provide appreciation beyond a pat on the back for those trainees that are doing the extra coverage that isn't necessarily voluntary? And again, kind of going back to what I was talking about before of avoiding resentment and these kind of negative feelings then that surround the individual who is having the child.
I love that question, and Dr. Sarkar always brings the good and challenging questions that I certainly cannot answer, right? It is definitely a struggle. We're actively working on this, and I'll broaden it to say it's not just relevant to individuals who leave on parental leave, and individuals can leave for any reason. Someone can leave fellowship altogether, and there is this impact. And so the broader question is what redundancies can we build uh, to help our trainees, and the truth is that we actually don't, most programs don't have redundancies in a way that is fully satisfying to the trainees. I mean, you can build I guess coverage systems where you take away from other types of time, right? Research time, elective time, to cover individuals who are away, but then that means that someone's kind of getting a bit of a short end of the stick. And so what it would really require is to build physical redundancy, so having more than what you need in terms of the number of fellows. And so that gets to finances, right? Fellowships are covered through clinical dollars, and those clinical dollars come from the federal government, and we have to apply for slots and justify these slots based on clinical need. So it's just not a very clear solution at the moment, but certainly something that I fully recognize, and we are definitely dealing with this in our own division and have dealt with it previously. I think short of just trying to create a culture where everybody is supportive of one another and not making it about parental leave per se, right? Because anybody can be out for any reason at any time. You could have a sick relative, you could have, you could be sick and someone's going to need to cover. So some of it is just, that's what we need to do for one another in the workplace. And so really creating that culture from the ground up. And no, I don't really have another way to show, to compensate or to show appreciation besides, the usual ways that we show appreciation with thank yous and trying to give back time when we can. But it is a struggle. I don't have a really good answer.
I think what you were mentioning is the current workforce is not really set up for that. And I think that's one of the main challenges that we have in this area is that we're putting our leaders and our administrators in positions where just it's very challenging to provide this coverage. And 12 states and Washington, D.C. now mandate 12 weeks of paid leave. As you mentioned, people can go for other reasons as well, for FMLA or other potential covered reasons. And so my hope is that medicine will start to build towards creating some of these redundancies that sort of expects people to go out on leave, because soon, there might be a national law that mandates 12 weeks of leave in every state, and there might be increasing coverage responsibilities. And my fear is I think the medical staffing would be much better if we can sort of proactively understand that that's coming and build these systems in, as opposed to sort of a reactive process, which is what the majority of leave coverage has been. And it's not surprising that people, as Dr. Sarkar's question, suggested, it's not surprising that people are resentful if you only have one short period of time to do research during your fellowship, and then it gets taken away because you're providing coverage for someone. That's completely understandable. So thinking through how do we build in some redundancy into the system, and increase the ability to provide this coverage. It's a tough spot that our leaders are in, but an important one, and one that I think will become increasingly important, because by comparison, other industries have significantly longer leaves. There's a website that I like to use if I am invited to give a talk. I hope this doesn't dissuade anyone from inviting me to give a talk on parental leave at your institution. But when I do get invited to give a talk, I look up that institution's state or environment, and I look up healthcare adjacent industries in that. So I recently gave one at Mount Sinai, and I looked up in Manhattan other healthcare adjacent industries, so pharmaceutical companies, healthcare consulting companies, et cetera, that physicians could potentially choose to go work for. And there's a website online. It's called Show Us Your Leave. It's run by a news website called The Skim, and I love it because it's a large database. You can filter by location and see the parental leave policies. And if you think about what physicians' parental leave policies are at other places. So if a physician decides to leave and start working for a pharmaceutical company, and they're being offered 6 months of paid parental leave and full coverage for infertility benefits and, a flexible work environment upon returning, like clearly that's not something that we can cover yet in the healthcare workforce, but it does provide a little bit of impetus when we're looking at retention issues to think through, like, how do we build into the system so we can give people, 12 weeks without really burdening their colleagues.
And there's another question that, oh, I'm so sorry, go ahead. Okay, there was another question in the chat that kind of piggybacks onto this from a different perspective, but what are your thoughts on mandatory paternity leave that's of similar length to maternity leaves? As it was notable in your study and has been noted in others, is that the paternity leaves are significantly shorter.
Short, 1 week.
Yeah, and so it supports and reinforces why men don't feel the impact on their careers, or why they may say they don't feel the impact. And then, of course, we all know there's other benefits to paternity leave, being a primary caregiver and things like that. So just what are your thoughts and Dr. Carr's thoughts on mandatory paternity leave?
Yeah, so I will say that the paternity leave is incredibly important, that not every family is one man married to one woman. You can have two men married to each other, you can have two women, et cetera. And so you want to think through all the different families that are represented in your institution and making sure that you're not creating a bias, because if you're only going to give parental leave to a birthing person, then you're going to potentially build in some inequity there. And I will also say that if you, even in the presumed typical relationship of one man married to one woman, you have many physician couples that are married to each other, and only giving leave to the woman creates this expectation. There are a lot of studies that show that men who took paternity leave have a greater amount of caregiving responsibilities down the line, because otherwise the woman sort of becomes the presumed default parent. And, many of us might have heard of or experienced where it's like, the dad can't, doesn't know where the kids, pediatrician is, doesn't know where XYZ is. There are a lot of caregiving responsibilities that happen down the line. And so if you only are giving parental leave to one partner, you're sort of setting that person up as the default to own those responsibilities. And so then, only the woman can request time off to bring the kids to a pediatrician appointment. And that's not creating an equitable workforce.
Lauren, if you have a moment, if you can share the link for the Show Us Your Leave website. If you could put that in the chat, that would be great.
Will do.
I have another question for you, Lauren. I always try to think about unanticipated effects of new systems that are put in place for really great reasons, and then somehow they just don't work out in the way that we had hoped, and sometimes can make disparities worse, exacerbate biases. So you talked about there is a move toward more competency-based training, and I have to say, when I hear that, I think, does this mean there's more subjectivity in the determination of competency? And then, of course, I think about, well, who is often most disadvantaged by such subjective criteria? And, and no surprise, women and minorities tend to be. And so it does give me pause to think about moving in a direction away from time-based training and more toward competency-based training, because that would have to be on an institution by institution basis, a faculty by faculty basis. What do you think are the unanticipated effects, and are you a proponent of this system, and why?
It's a great question. I will say, so you are absolutely right that there is a lot of data. There's a great JAMA article, a great and heartbreaking JAMA article on bias experienced by trainees who are underrepresented in medicine. And it includes both quantitative and qualitative data. So quotes from these trainees and the things that they have experienced, and things, that were said to them, the respondents to the article. It's clear that medicine is far away from being a place where we can rely on competency-based education as something that's going to be assigned equitably. And in there's a paper, I'm trying to remember the first author. The senior author is Dr. Amy Aksentenko, who is a gastroenterologist, and it was looking at internal medicine residency evaluations at the Mayo Clinic. And they looked at women who had just returned from parental leave, and men who had I think everyone in this couple, or in this study, was a man-woman couple, and the men's partner had just given birth. And so the women who had just given birth compared to the men whose partner had just given birth, and assessing their evaluations. And there was essentially no impact on the men's evaluation when their partner had given birth. And for the women's evaluations, when they returned from having given birth, their evaluations were significantly lower. And I refuse to believe that every woman who gives birth suddenly clinically becomes much worse. I would bet that there was probably a significant amount of bias that went into those evaluations being lowered, or potentially, sleep deprivation from inadequate leave. But that's another possible contribution. So your point is very well taken, that there are major issues with competency-based education. I do recommend that programs be engaging in sort of anti-bias for these evaluations, because evaluations are subject to a lot of there's a lot of subjectivity in them. And so making sure that as part of an anti-bias strategy, both we're talking about trainees appropriately, because that affects a lot of parental leave, but also for faculty evaluations, thinking through making sure there's people in leadership roles are engaged in anti-bias strategies, so that you're not getting the like, oh, she's nice, she brought cookies in for the team kind of things that are put in competency evaluations. Whether or not I'm a proponent is a good question. I will say this is not my area of expertise. I don't know that I have enough to answer that. My focus is more on gender equity, so I know the issues related to bias, but I don't know if competency-based education is if we're there yet. It's a good question that I'll have to defer to someone more knowledgeable on, with the caveat that you're absolutely right that those are major concerns. And the note that it's okay to delay fellowship graduation if you need to. So I delayed my fellowship graduation because I was in a one-year program, and a one-year program, 3 months matters a lot. And so it's part of the hepatology guidelines for that one-year fellowship do not allow you to take leave without delaying. And I don't think that was inappropriate. I think that I'm grateful to have had the extra time because it was a one-year program. And so the transplant guidelines require that. I worry about it more when it's in internal medicine residents, because you can imagine if you're interviewing for GI fellowship, which is already incredibly competitive, with the hope of becoming a transplant hepatologist, and you have to say, I'm really excited to start your program. I'll start a month later than my colleagues. You're already fighting an uphill battle. So I do worry about it from a residency standpoint.
Excellent. Well, we're almost to the top of the hour here, and I don't see any other questions in the chat or in the Q&A section. So I think we can conclude this session, and I'll turn it back over to Brian Valeria. But thank you so much, Dr. Feld, for reviewing your amazing article, and I'm excited to work with you on looking more into this and the transplant professionals as well. And we thank you so much for your time today and your resilience in getting through the presentation with those sneaky little toddler viruses that come in. But this was an amazing presentation, and the recording will be available, and Brian will go through that. But thank you again so much for such a wonderful presentation.
Thank you both so much for inviting me and for the opportunity.
Thank you. AST would like to thank Drs. Feld, Alvey, and Carr, and the leaders of WHCOP, and all of our attendees for today's session. Please remember to complete the evaluation survey in Zoom and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. To learn more about AST's Women's Health Community of Practice, please visit myast.org/COPS or connect directly to the WHCOP Hub online. Thank you all again for today's excellent session.